First of all, tirzepatide is a dual incretin. It has two targets, GLP-1 receptors and GIP receptors. Dulaglutide is a typical of the first generation GLP-1 drugs that target just GLP-1. And the question that came up with this trial is targeting two better than targeting one? The main trial was called SURPASS CVOT, and it was a non-inferiority trial. And the reason it was done in that way is that is a regulatory requirement that if you want to show that a new therapy is as effective, you have to do a non-inferiority trial, and dulaglutide had done a trial known as REWIND, which had shown that it was reducing adverse cardiovascular outcomes. The primary comparison in SURPASS CVOT was a three-component endpoint: cardiovascular death, stroke, and myocardial infarction. So a narrow endpoint. That was chosen because REWIND had used that endpoint. However, we adjudicated a broader range of endpoints. In fact, my team at the Cleveland Clinic did the adjudication. And there were three other components that were looked at. They included a hospitalization for heart failure, revascularization, and major worsening of kidney function. In addition, we also wanted to look not just at cardiovascular mortality, but at all-cause mortality. So the analysis that I did and reported was a six-component endpoint: all-cause mortality, myocardial infarction, stroke, revascularization, hospitalization for heart failure, and major worsening of kidney function. And we did this with the intention of determining whether or not the dual targeting agent, tirzepatide, was superior. And what we found is that tirzepatide was associated with a substantial reduction in the six-component endpoint. Hazard ratio was 0.84 with a p-value of less than 0.001. We also did sensitivity analyses where we took out the renal events and just looked at five components. And it also had a very good hazard ratio, 0.86, with a p-value of less than 0.001. We took out two components, kidney worsening and heart failure. So four components, and it was still a very strong reduction. And finally, we looked at all-cause mortality alone, just all-cause mortality, probably the most important endpoint of all. And the hazard ratio was 0.84, and the p-value was 0.002. So we really saw a robust, across-the-board reduction in cardiorenal morbidity mortality with a dual targeting agent like tirzepatide compared with a single targeted GLP-1 agonist, dulaglutide. The most compelling aspect of this study is that when you look comprehensively at the things that matter to patients, when you take one of these drugs in the setting of diabetes, obesity, and pre-existing cardiovascular disease, that you see a real difference between tirzepatide, a dual targeting agent, and a single targeting agent like dulaglutide. That's really what counts. And it's not the regulatory endpoint that was required, but it is the clinically relevant endpoint that was benefited. Well, I think obviously physicians need to consider whether their patient would be better off taking a dual incretin targeting drug like tirzepatide rather than the more conventional first generation GLP-1 agonists. It's a choice that patients and physicians should be made together, using shared decision making. But for me, I think the answer is reasonably clear that there can be additional benefits for patients in targeting more than one incretin.